Good evening, everyone. Many thanks for coming for our webinar. This is 7th webinar or series of educating healthcare practitioners during COVID. And today's chair is going to be Dr. Julie Sanders and Miss Jeni Palima. And over to you, Jeni and Julie. Thank you.
Thank you very much, Bhuvana. I will introduce our first speaker. So she's a senior lecturer in Agile University. She also works as a respiratory nurse specialist and has held senior clinical roles in the NHS and overseas for several years. She is also a member of the Association of Respiratory Nurses Specialists Executive Committee and currently serves on the British Thoracic Society Quality Improvement Committee and more. So please welcome Dr. Carol Kelly. Over to you.
Thank you, Jeni. I hope you can hear me, and I think Bhuvaneswari is going to share my slide presentation with you. But Jeni's introduced me. Can I just say that my days in cardiothoracic ended about 25 years ago. I was a sister in coronary care unit for several years before that. But then I went to the nicer speciality when I developed an interest in respiratory care, and I've been there ever since, and have no desire to go back to cardiothoracic. But I know what a great area you all work in, and I do have some very fond memories of it. So, but in my new guise of a respiratory nurse specialist, I carried on with my career and developed an interest in research. And I suppose that's really where the common thread is that I'm presenting to you today, because Bhuvaneswari asked me to present a seminar that I presented at university. It was under the theme of COVID-19, and it was particularly related to the navigation of funding, ethics and recruitment of frontline clinicians during a pandemic. So if you can imagine when you're really starting that concept of designing a study, but you know it's an absolutely time critical manner that you want to start recruitment as soon as you possibly can, but you have to navigate all these other issues of particularly ethics and funding, and recruitment isn't quite so instantaneous. So next slide, please. So the study I'm introducing you today is a nurse COVID study. It's a qualitative exploration of experiences of nurses with respiratory skills working during the COVID-19 pandemic. And obviously, as you can imagine, lots of clinicians were on the forefront of the pandemic response and in the front line of working. But respiratory nurses in particular took the brunt of this, as they were able to go into areas of critical care and high dependency and already had an established skill set that was easily transferable. It was also easy to deploy them to introduce training and teaching for lots of other healthcare professionals as well. So again, it was there was a need there really to try and capture this experience in order that we can learn and we can plan and we can feed forward what we've you know the lessons learned, so that we can be better prepared either for the second wave of the current pandemic or indeed for future pandemics. So which comes first, the chicken or the egg? Next slide, please. First of all, I'd like to really highlight again why this study is important. It is about learning what skills were needed, how staff were deployed, and how we can plan how this will formulate into and feed into public health policy in the future. Next slide, please. And I think, you know, really we've got to think about history. Why do we need to learn these lessons? Why do we need to think about how we plan for the future and move forward? And for those of you maybe familiar with images like this, for others it may be quite new. This is a picture of a hospital, a temporary hospital in 1918 when the Spanish flu broke out. This was a massive impact globally, and it's one of the last biggest pandemics and has been termed the mother of all pandemics, because we feel that a lot of the viruses evolved from the Spanish flu in 1918, although I'm sure there were precursors, but we just didn't have the ability to collect that data in the picture at the time. During this pandemic, which ran between 1918 and 1920, so exactly 100 years since, between 50 and 100 million deaths worldwide have been estimated. So that's absolutely enormous impact. Just to give you some context there, in the UK today, we're estimating about 41,000 with almost 900,000 worldwide. So, you know, there's a big difference there. Whether we'll ever get to those numbers, let's hope not, and let's hope we are better prepared already. But certainly we have to mitigate against this impact and try to learn the lessons we can so that we can stop the second wave, or at least minimise it and make it as containable as possible. Next slide, please. So we've got the model in the parent, and we know that a lot of hospital admissions are respiratory presentations. So again, we've got this rapid novel configuration and reorganising of services. We all saw the Nightingale wards go up very, very quickly, and a lot of respiratory nurses and also respiratory physiotherapists were deployed to these temporary wards. And we wanted to capture the experiences, adaptations, innovations that these individuals were experiencing. But also importantly, I think we want to capture the burden on individuals and healthcare professionals, especially from a psychological and a social context. We've already had some preliminary data that, you know, suggests to us that, you know, the impact of COVID not only on the individual but on the family as well as being quite significant. And obviously this is all about informing workforce planning, education and solutions for the future. Next slide, please. And as a bit of a champion of respiratory nursing myself, it's always an opportunity to showcase respiratory nurses and nursing and what we do and what we can offer in a very similar way to you as cardiothoracic specialists want to also champion your speciality. And a lot of the skills that we have are particularly transferable in COVID-19. Next slide, please. I think I like to show this picture because I think this really epitomises, to me, respiratory nursing in the 21st century. This is an outreach worker going to homeless people to try to educate them regarding the dangers of COVID. This was in the initial peak, and also to give some strategies for them to be able to protect themselves and protect others around them. And it really sort of, you know, the lady with the lamp in the 21st century, I think is captured really nicely in that picture. So next slide, please. So the challenges of starting a study in a time-critical manner, I think it's, you know, it's all about this. We saw this peak, we saw this sudden rise, and we've got this apparent fall, and obviously it is a real fall, but whether it'll stay down, we really don't know. But we knew we needed to start data collection ASAP. Next slide, please. So, well, I was approached by colleagues from across the country, and we are a team of respiratory nurses, 5 respiratory nurses from Glasgow right down to Southampton. Obviously, I'm in the northwest, and we wanted to get started as quickly as possible. So how do we go about this, knowing that we've got this very, very finite window to start data collection, but we have to go through all the usual channels of permissions to get there. So what we did, we went to the HRA website and we did the decision tree and found out, because it was only healthcare professionals that were included in our study, we didn't need HRA ethical approval. So that was a bit of a, well, it wasn't a bit, it was a huge sigh of relief, because that can be quite a protracted process in itself. So we went through the university and we got ethics approval there, which was quite timely and quite straightforward. We then made a call for data collection to start, because again we wanted to engage. We designed our study that we were going to ask people to collect diaries, because we didn't want a snapshot. We didn't want to do a survey, although we did do a short survey, but the main study in itself, we wanted to really capture the richness of what people were experiencing, and potentially over a longitudinal time span. So it was really important that we asked for people to start the data collection, even though we weren't asking them to actually submit or start to be interviewed or actually take part in any data collection at that time. We also needed to find some funding to do this study, so we had to make an application for funding, which was initially to the NIHR COVID-19 call, and I will fill you in a little bit more about that later. So next slide, please. I think, Bhuvna, you need to just click me through this so we can see all the different ways that we tried to get this message out. We used various social media. We enlisted the help of the Nursing Times, who ran a piece on it. You can keep clicking, Bhuvna. Thank you for a few. And we did it through our university web pages, and just really tried to, and click again and again. Really trying to embrace it as much as possible, using the likes of Twitter and Facebook. And again, finally, it was the university web pages that I used as well. One more click, I think, and then we're done with that particular slide. Thank you. So it's really just making sure that we went far and wide and really using all our influences as best we could to make sure we got the message out there. And we were really pleased, even though we weren't asking for respondents or participants at that stage. We actually had 10 people who approached us straight away and said they were really keen to be involved and to start these diaries. So that was really encouraging and helped to support us. Next slide, please. So we had an immediate response from participants. We advised diary, and this was on while we were still waiting for ethics approval to be fully implemented. We had advice from the chair and the chair of our ethics committee and another independent individual who just said that if we advised participants to collect the diary for personal reflection and potential revalidation, then that would enable us to start this data collection as soon as possible without waiting for ethical approval. There was then a point in the future that we would ask people to submit their diaries for analysis, and the research study would actually start. So we secured support from the HEIs to do this, and it was the Wessex ARC, if any of you are familiar with the Applied Research Collaborative Network nationally, who actually supported us, and we eventually got ethical permission. We got the funding outcome from the NIHR COVID-19 rolling call, which was unsuccessful. And there's a surprise to any of you who put in funding bids, because we know how competitive these things are and how frustrating it can be. We have since recycled the bid, as is normal practice with these things, and we have submitted into another bid. So we're currently waiting. What this has done is it's shifted our timeline. So we've kept our participants warm, so to speak, by going back out with social media and, giving messages that, are encouraging, that to say we still want them to collect their diaries. We think it's very relevant that they collect their diaries, and especially in the light of another potential second wave of this and a second spike, I think it could be quite interesting to have that more longitudinal perspective when the diaries are actually submitted. Next slide, please. So that's it really, and I think the reason I'm here today, and the reason Bhuvna's invited me, is to sort of share the lessons that I've learned with you. And I think when you're faced with such an instantaneous opportunity to actually collect data on something that's really contemporary and really topical, I think it's to be brave, seek advice, don't be afraid to get that advice, and use things, people like chair of ethics committees to give you that independent advice. Make sure you've got that transparency and integrity, because that really feeds them forward into your research and anything you do after. Teamwork is essential. I say we're a team of 5, and it's really sharing that workload and using each other as sounding boards that's very helpful, and use all the support mechanisms that are available. Funding is a dilemma. It always will be, I think. So it is that case of chicken or egg. I'm not really sure whether we got it right or not. Hopefully in due time we will see that. But with this, I thought this was another very relevant and poignant picture when we think of all the debacle at the moment and the debate around wearing masks. Should we wear masks? Shouldn't we wear masks? I'm not sure whether it's reassuring or not to know that they had exactly the same dilemma and exactly the same debates in 1918. What have we learned? Doesn't seem like there's an awful lot, does it really? So that's the end of my presentation. So thank you very much for listening to me. Bhuvaneswari has explained that I will be leaving this meeting shortly, but I'm more than happy to take questions, any questions now if there are any.
Thank you so much, Kelly. It's really nice talk. Thank you for coming. I have a simple question. So how are you going to, I know that you asked the respiratory nurses to collect the diaries. And do you have ethics for that? And how are you going to analyze it?
Yeah, we do now have ethics. One of the, and obviously there were some recommendations and corrections that we had to make from our first approval, and we will obviously, all diaries will be anonymised once they've been submitted. We'll be very aware of confidentiality and make sure that all names, etc., changed of both individuals, but also trusts, colleagues, etc. So we'll put all those precautions in. We're giving everybody the option of submitting those diaries either in a paper format or electronic. I'm pleased to say that most people have chosen the electronic format because, as you can imagine, as for researchers, that's a much better, much easier format to handle. And if we got paper diaries, it means that we'll have to return them in some way. So we're hoping we don't have any paper diaries. We've had a few electronic ones, and I'm hoping there aren't any paper diaries. But if they are, we've got contingency plans to deal with that. I hope you found it useful. Obviously, if you have got any other questions, Bhuvaneswari will always be able to pass those on to me if you want to go through her, or you're happy, I'm happy for you to email me and Bhuvaneswari can give you the email address again. So I hope that was helpful. If you have got any more questions, I'll hang around for a few minutes, but if not, Jeni, I'll hand it back over to you.
Okay, thank you very much, Dr. Kelly. Any more questions, guys? You can answer your questions in the chat as well if you like. Thank you very much, Dr. Kelly. That was a very informative and interesting topic. So I will move on to introduce our next speaker. Our next speaker is the Director of Clinical Research, Quality and Innovation at St. Bartholomew's Hospital, developing research and clinical academic career opportunities for nurses and allied health professionals in cardiovascular care. She is also the Society of Cardiothoracic Surgery Nursing and Allied Health Professional Academic Lead, a member of the Association of Cardiovascular Nursing and Allied Professions Board, and is a Florence Nightingale Foundation Aspiring Dean Scholar. So please welcome Dr. Julie Sanders. Over to you.
Thank you very much. That was a very comprehensive introduction. Yes, I work at St. Bartholomew's in my day job, and Bhuvaneswari is currently kindly going to do my slides for me. So as Jeni kindly said, I work at St. Bartholomew's during the day and also Clinical Professor of Cardiovascular Nursing at Queen Mary. And I'm the SCTS Nursing and Allied Health Professional Academic and Research Lead. So we've been working across all specialities to increase cardiovascular research. So I've been asked to talk to you about the importance of clinical research in cardiothoracic surgery today. Next slide, please. And so the kind of plan of over the next kind of few minutes really is to give a brief indication of why we think cardiothoracic research is important. Possibly a little bit aside from the obvious, the UK cardiac surgery research priorities, so that we know which areas are particularly relevant for us to be researching, and then to highlight some of the nursing and allied professional research initiatives that we have within the SCTS. So that's the Nursing and Allied Professional Research Group and the Cardiothoracic Interdisciplinary Research Network, with some tips at the end of how you can get involved if you're interested and would like to. Next slide, please. So just to give it a little bit of context, as I say, St. Bartholomew's is now one of the largest cardiothoracic and cardiovascular centres in Europe. we see over 80,000 patients in total now at our centre, with over 2,000 surgeries, cardiac surgeries per year. But actually, we're quite a historical site, and we're the oldest hospital working on the original site of which it was built, and it was built in 1123. And although I feel quite old, I wasn't actually there at the grand opening there, but I did join after the merge of the three centres, which is the picture on the top right-hand side of the new kind of state-of-the-art centre. And the bottom picture illustrates the William Harvey Research Institute at Queen Mary, University of London, where my academic links are. And QMUL is ranked one of the fifth UK university looking at cardiovascular, endocrine and inflammatory research. So it's well known for its research excellence internationally. So I come from a really interesting and historical cardiac research environment, which is why I'm so passionate about making sure that we have good research opportunities for all. Next slide, please. And this is some of my team, because as well as developing cardiovascular research across all specialities, we have a developing nursing and allied professional cardiac surgery group. You'll see Ashley on the top right, and he'll be speaking a little bit later on. Still not smiling, Ashley. I'll have to work on that as your supervisor. But Tracy, Rosalie and Melanie are all doing their PhDs in cardiac surgery field, and Teresa is one of our clinical education leads, but actually recently completed the NIHR 70 the NIHR research internship, and is one of the NIHR 70 senior nurse research leads. And her role is about improving research in practice, so that actually we're doing a lot more research as part of clinical practice and utilising the research for evidence-based practice. Next slide, please. So this next section is just a little bit on why cardiothoracic research is important. And so across Europe and the USA, we have over 200,000 surgeries performed in each of those continents each year. But cardiac surgery is actually considered the unborn child of global surgery. And that's because since the Lancet Commission 2015 report, cardiac surgery has kind of fallen behind other surgical specialities in terms of meeting the unmet need for surgery. So there are still over 4.5 billion people without access to cardiac surgery. And certainly other specialities like paediatric surgery and neurosurgery in particular have really made greater strides as a profession globally to enhance the speciality and to move forward. And that's been aligned to the fact that we don't have as much of a strategic policy for cardiac surgery at all. We don't have a unified global database of the number of cardiac surgical procedures and outcomes, for example. And certainly, if we look more closely at things like postoperative complications, it's now believed that postoperative complications should be considered a global public health concern, and that we should be spending a little bit more time in our research time knowing more about this. But equally, there's been a real shift from mortality and morbidity outcomes to also include those that really matter to the most of people. And certainly globally, there was a Health Ministers Initiative which came out in 2017 that said we really must measure and invest in those patient-reported outcomes and those that are most important to our patients. Next slide, please. So within the UK, actually, we don't do too badly in terms of research. So we have 15% of the world's top-rated scientific output, with only 7% of the world's researchers. So actually, if you think about it, we actually could do an awful lot more if we had more researchers in this speciality. And to put it a little bit into context, if you were to put all the cardiothoracic academics kind of in a line, those that work in Leicester would outstrip those that work in the rest of the UK. And so even within the UK, we're cardiac surgery researchers. There are far fewer of us than there are in other surgical specialties. So we need to, as a profession, be really supporting and driving development of individuals and teams in cardiac surgery research. Equally, there's a real lack of national nursing and allied professional researchers overall, but particularly again in cardiac surgery, which is why at the SCTS there are the initiatives that I'll talk about a little bit later. But the good news is, as I say, we do produce a lot of the world's top-rated scientific output, but there's going to be increased investment. So more excuse me, investment in life sciences, with also a predicted kind of 50% increase in spending in clinical trials to be funded over the next 10 years. So the future is rosy, but what we need to do is to train and get more people interested in undertaking research. Next slide, please. So you don't have to see necessarily all of the fields at the bottom. I guess what I would like you to look at these as just the level of height of the charts. And basically, you've got a list of all of the hospitals and then their number of patients that they recruit into trials, and then the number of multi-centre trials that are carried out by each unit on the bottom graph. And really what this visually represents is that there are probably about 5 or 6 centres that are doing the majority of the research. So that would be Southampton, Oxford, Leicester, Bristol, for example. So what we need to do is actually to try and encourage a little bit more research in each of the other centres by recruiting even maybe say another 10% of patients. We could get really large numbers of patients in the trials that we do, which will make them really world leading and give really good answers to questions that we need addressing. Next slide, please. So when you're looking at high quality care and therefore the research that we need to do, we should be looking at structure, process and outcomes. And if we focus on the top right hand part of this diagram, and this focuses on the majority of the cardiac and cardiothoracic surgery. And what it does, it says that if you've got a high caseload of patients per hospital and a high risk at baseline, that those patients and those conditions should be looked at, and the research should be looking at outcome measures and also how that links to process. So certainly for cardiothoracic surgery, we'd be looking at outcome and processes. When we come to looking at outcome, there's been an awful lot of emphasis in the past relating to mortality outcome. For a very long time, surgeons were only interested in whether you lived or died after the operation. And it's become over the last maybe 10 or 15 years a little bit more common to look at the morbidity, to look at the complications after surgery and how they might be mitigated. And as I said earlier, a lot of the current work is also about including patient-centred outcome measurements as well. So we should be looking at process and outcomes, and those outcomes should include mortality, morbidity, and patient-centred outcome measurement. Next slide, please. These are graphs from the NIHR database, and really this kind of shows that we've done an awful lot of work in reducing the risk and reducing mortality outcome. And the graph on the left is the mortality over a number of years from all cardiac surgery. And the graph on the right is isolated first-time coronary artery bypass graft and mortality rate. And you'll see that for the all cardiac surgery, mortality in around 2016 was about 2.5, 2.6%. And for the isolated first-time bypass grafts, it's just over 1%. To make considerable changes and for research to make a considerable difference in mortality rate, we would need to do something pretty dramatic. So it means that actually to make a really big difference, we should be looking at morbidity and patient-reported outcomes. Next slide. So we actually haven't been very good and very consistent at reporting morbidity outcomes. And those are things like reoperation rates and bleeding, maybe significant renal failure. And this was the first report from NIHR that had actually started reporting on some of those outcome measures. And I guess the kind of message from this is something that we need to work on. We need to look at data completeness. We need to look at standardization of definitions. But we are beginning to do that. So there's a significant amount of research work that we can do to look at morbidity, reducing the risks and improving outcomes in this way. Next slide, please. Part of the challenge in looking at morbidity relates to both the definition and the measurement. So, for example, there is a plethora of definitions of morbidity. They include all sorts of things that, you know, if you would look at one paper, it won't have looked at morbidity in quite the same way as another paper. For example, there was a systematic review that looked at bleeding and MI outcomes after cardiac surgery, and they'd reported 8 different definitions of each of those outcomes. And so there really makes comparisons and meta-analyses very difficult. And so what really there lacks is a global policy or a UK policy for this, and very few countries reliably record this. And this has a big impact because if you think that each complication actually costs approximately £12,000, and if you decrease the waiting time and you decrease the complications, then actually you can increase more operations. It will have a really big effect both on patients but also on health service delivery. Next slide, please. So if we just have a brief look at patient-reported outcomes, most of the, as we said earlier, that most of the emphasis is now moving towards the outcomes that matter most to patients. And the guidelines for ERAS, which came out last year, actually have included patient-reported outcomes in that. Next slide, please. But actually what we've found to date is that only 29% of cardiac surgery trials so far have reported patient-centred outcomes. But moving forwards, patient-reported outcomes are now part of the core outcome set. So every trial moving forward should have quality of life as one of the outcome measures. Next slide, please. This leads a little bit on to the next section as well in terms of patient-reported outcomes, but also on the level of evidence and where we need to be looking at our priorities for research. So I'm sure a lot of you are very familiar with the ERAS guidelines, but these arrows, these blue arrows on the left-hand side, are really to indicate the number of sections within the ERAS guidelines that are based on a low level of evidence. And so actually to boost those levels of evidence to make sure we are delivering evidence-based practice, we should be focusing on providing and getting more evidence in these areas. Such outcomes are the use of patient-reported outcomes, as I say, looking at clear liquids, oral carbohydrate loading, nutritional deficiency, etc. So these should provide some basis as well as to where more evidence and more research is required. Next slide, please. So as I say, I'm just going to talk you through a little bit about the research priorities in the UK, very briefly. This was a James Lind Alliance process, which was a 3-step process. I won't go into them all in detail, but feel free to look at this at your leisure. But basically, there's a first stage questionnaire goes round to patients, carers, and health professionals to ask them what is your top, what would be your research question? If you wanted a question answered, what would that be? That then gets looked at, the systematic reviews are completed, and of those themes that come out, the list of unanswered questions is produced as a long list. Then that long list goes out again for people to rank those as their top 10 priorities. And then that medium kind of list then goes to a workshop consisting of health professionals, carers and patients, and they then debate and work out what the top 10 priorities should be, weighting up all of those previous rounds. And then this creates that list of top 10 priorities. Now these are important because they are the areas that funders in particular pay good attention to when they're trying to fund research. So it would be very good for all proposals to be focused on these priorities. And thank you, Profana. And these are the top 10. So as you'll see, quality of life is the top priority. And there's a range looking at frailty, prehabilitation, heart valve intervention, atrial fibrillation, for example, and infection. We also have a 3D bioprinting priority in there too. So these are the top 10 that, as I say, if you're interested and going to be doing a project, that probably the projects over the next few years will be based around one of these 10 priorities. Next slide, please. So just to give you a little bit of insight into what we're doing at the SCTS in terms of promoting nursing allied professional research initiatives. Next slide, please. So we want business as usual in terms of research. We know that research active trusts have better patient outcomes, patients have more confidence in staff, and nurses who value research are more likely to use research findings in practice. This is how I spend quite a bit of my life, actually, trying to convince people that research is a really good thing, not to be too scared of it and to get more involved. And I think basically we don't do enough research as nurses and allied professionals, and that's why we're a little bit scared and kind of slightly run a mile when the thought of having to do it or accessing it is kind of put to us. So our vision at the SCTS, next slide please, Bhuvana, is that we want to encourage and promote and assist in the development of nursing and allied professional clinical academic career, but also research opportunities across the UK. Next slide, please. So we have a nursing and allied health professional research group, and really this is a first step in creating a community of cardiothoracic researchers and to encourage and to support the development of nursing and allied professional-led research, to share expertise and to highlight research opportunities. Next slide, please. And we have a number of initiatives that we currently provide. We have the group, we meet at the research meetings, national research meetings and the annual meeting. We have a research directory, which are those that are prepared and able to provide mentorship and support. We're trying to expand an online research resource library and also, as I say, provide details of research events, etc. Next slide, please. I'm hoping that many of you who have joined us have heard about the Cardiothoracic Interdisciplinary Research Network. We've spoken about it in different forums throughout the SCTS and at different meetings, but really this is a collaborative network of both trainees, nurses and allied professionals, and our ambition is that we have representatives at each of the centres across the UK. If you think back to that slide where we had that 5 or 6 centres were the key centres for doing research, what we want to do in terms of building capacity at all other centres is that we have dedicated people that will not necessarily undertake all the research, but will help facilitate and get research up and going at those centres. So we're really keen that if anyone is interested in joining this network, that they also get in touch and let us know. Next slide, please. And this is just a brief slide on some of the advantages of taking part. We've been involved in doing a Cochrane review. We've done some benchmarking work and surgical site infection work, which has been published. And we're part of an associate PI scheme, which means that nurses, allied professionals and trainees who contribute significantly to the development and delivery of some of the trials actually get a nominated role, if you like, within the NIHR as an associate PI to help build up research expertise, and that is a recognised role. Next slide, please. So how to get involved. These are kind of a couple of slides just to give some contact details, etc. If you're interested in the NARG, then please, there's a section on the website and you can enter through your SCTS membership. And if you're interested in the Cardiothoracic Interdisciplinary Research Network, then either Luke, Vicky or myself. And we do have a Twitter handle, so please do get involved also that way. Next slide, please. And just as our 2 events, we have a research, national research meeting every year. This year it'll be a webinar, so please do sign up. It's on Saturday, the 7th of November. It's free and it's a really nice, friendly day. And of course, we have the SCTS annual meeting next year, abstract deadline, 23rd of October. Next slide, please. Thank you very much.
Thank you very much, Dr. Saunders, for giving us an insight on the importance of clinical research in cardiothoracic surgery. That was quite helpful, actually. Over to you for the next talk.
Thank you very much. It's my pleasure to be able to introduce the next 2 speakers who are going to talk about the impact of COVID on research. I'd like to introduce, although you all know her exceptionally well, Bhuvana, who is an NIHR Postdoc Fellow. Bhuvana.
Thank you so much, Julie. Thank you for introducing me. I'm going to, as you all know that I'm Bhuvna, going to talk about the impact of COVID-19 pandemic on my postdoctoral fellowship. So my project, what I was supposed to do. So I have been given a £1 million from NIHR to do the project, and my plan was to develop an e-learning package for an endoscopic vessel harvesting in cardiac surgery, and then do a multi-center cluster randomized trial. So my trial was going to be for 12 hospitals with 24 trainees and 240 patients. And I was going to collect trainee and patient satisfaction and also a learning assessment of goals, as you all heard about the global operative laparoscopic surgical assessment, and also 12-month patient follow-up and a health economic evaluation and doing a CT angiogram at 6 months. But however, my project, I couldn't able to carry on because of COVID pandemic. So the impact has happened for everybody, not only me. Everything continuously passed and all my sponsors pulled out because due to new challenges posed by the COVID and also new regulations and also posed by the British government. The main problem came after the Excel trial. Most of you have heard about none of the companies can sponsor or do any randomized trials anymore, especially from America to British government. That was the main problem. All the sponsors pulled out, and plus in addition, everyone was more concentrating on COVID related research rather than the normal cardiothoracic research. So what I have learned from this, just to be patient, not to get frustrated. And as you know that lots of health issues come with this stress and everything. And one thing I have understood that this is a global problem. It's not my fault. In the starting, I was really upset why it's only happening to me. But when I looked at lots of other researchers and everybody's career has been stopped or paused. So what readjustment I have done? So I spoke to NIHR and they were really, really good about it, what happened to me. And they don't want me to give up. One stage I wanted just to give up and just to walk out of everything in research. But the NIHR said, no, revise the proposal and submit it. And I submitted the first stage, they agreed. And they asked, some of the reviewers asked me for the revision of very small, small complex issues. I explained to them and just planning to start in few months back time my research. So in conclusion, the one thing I learned is life is very complicated. Don't try to find answers, because when you find answers, always the life changes the questions. I always like this because it's always new questions are coming, and trying to find the answers is a very, very difficult thing. In conclusion, always keep smiling and everything will fall into place. This was given only 5 minutes for me, so I hope I have finished in 5 minutes. Thank you. Any question I will take at the end.
Thank you very much. I think it's a really key thing actually is to keep smiling, because there are so many things outside of control that you do have to kind of go with the flow to some extent. So thank you very much for that positive end message for obviously such a traumatic time for you and in your research. I'm going to hand over and introduce Ashley Thomas, who is our next speaker. And Ashley is a charge nurse at St Bartholomew's Hospital and is doing his PhD at Queen Mary University of London. And I'm going to hand over to him to explain about the impact of COVID on his research and his PhD.
Thank you, Julie. Okay, so good evening, everyone. My name is Ashley Thomas, as Julie said. I'm going to talk for the next 5 minutes just about how COVID-19 impacted upon my PhD research. I provided my PhD title just to illustrate the clinical nature of my research and why later it had such a dramatic impact. So my PhD title is The Recovery from Intensive Care Unit Acquired Weakness, Molecular Determinants and Consequences for Physical Recovery and Quality of Life in Patients After Cardiac Surgery and Severe Cardiorespiratory Failure. Next slide, please. So just to put it into a little bit of perspective before I continue, we were conducting 2 research studies at St Bartholomew's Hospital. One was called Variants, and that was looking at patients pre and post aortic valve replacement surgery, and Cleverer, which is the recovery from severe critical illness, especially in patients receiving extracorporeal membrane oxygenation, which we do a lot of in ACCU. So recruit 50 patients for variants, and the project was involving a lot of clinical work. So, for example, it involved intraoperative muscle biopsies, pre and post measurements of muscle mass using ultrasound, strength and functional assessments, questionnaires, health-related quality of life assessments. So I had to be with the patient and have meetings with them quite regularly for this research to work. As you can see, I'm a Band 6 charge nurse in the intensive care unit at St. Bartholomew's Hospital, and currently I am in my 3rd year of my PhD. Next slide, please. So at the end of March, I was required to return from secondment back into my role as a charge nurse in ICU. My responsibilities remain the same. However, as all of us, we all had the additional role in helping train the ward staff in things such as ventilation and caring for the critically ill patient. As everyone knows, the pressure and difficulty during this time was significant for all of us. And I just wanted to highlight, I concur with Bhavina that it was really heartening to have your research stopped. And even though at this time I wanted to continue, and even if I couldn't do any of the clinical work research, I wanted to do anything such as the writing or just looking over maybe some statistics. But as my supervisors quite rightly said, this is a global situation. Everybody's affected. And it is best not to overburden yourself when these situations are going on, and just to focus on the global catastrophe at that time, and then think about research once it is over. Next slide, please. So I'm going to talk with you a bit how COVID-19 impacted on certain elements within my research. And the first one is patient recruitment. Patient recruitment was suspended by the JRMO for St. Bartholomew's Hospital for both our research studies. And despite Cleverer being a study investigating patients in intensive care requiring ECMO, we were still unable to continue that because, one, all research that wasn't important for patient safety had to be suspended. Two, the COVID-19 group were considered a separate entity as a group, so an amendment would have to be. And our research was is an observational research, so it wouldn't benefit. There's no point doing that at the time that we were dealing with other issues at St. Bart's. And the other factor we had to consider was that once this pandemic had subsided, the patients we wanted to recruit for variants were very different now. When we started, the waiting times were similar for all our patients, and when we were having patients having aortic valve replacements, most of them were in a similar disease state, or they were having their surgeries in specific times. We had to then think that the patients now have had to have an extended period of waiting for their AVRs, and therefore the sample has slightly changed. These patients are now requiring the surgery more urgently than the patients that we were maybe recruiting. Next slide, please. So what about the patients we had already recruited? So patients who had already been recruited and were awaiting their surgery, and therefore their first study. We notified all patients of this, and we ended up withdrawing a total of 7 patients in the variant study due to COVID-19. Next slide, please, Bruno. What about follow-up? So it impacted follow-up, and again, this is where it becomes disheartening. Patients who had been recruited already received their surgery and had been discharged from a hospital and were just awaiting their final follow-up appointment that had to be cancelled. And this is due to a lot of the face-to-face appointments being changed to telephone consultations. Now, as you can see by the research that I was about my research, I had to see the patient to do the ultrasound and to do a lot of the tests. And because we piggybacked on them coming in for their routine cardiothoracic surgery appointment, or their intensive care follow-up appointment, they were changed to telephone consultation. So we were unable to fulfill the follow-up appointments. We did notify the patients of this, but it was actually quite sad to hear that a lot of our patients communicated they were saddened not to complete the research because they become heavily invested in the research as we do. And they like to see you and have a sign-off. And a face-to-face sign-off is very different to a telephone consultation. We lost 6 patients due to follow-up, and 1 patient in Clevera for follow-up due to the pandemic. Next slide, please. So our decisions were that we would suspend research, and I returned clinically, and also suspend recruitment. Now, when I returned from my clinical position again and I was put back into research, we decided that due to the follow-up times and us being able not to achieve a follow-up appointment and the samples changing for variants, we would not continue recruitment. Next slide. And we to do that because we have to understand that patient safety was paramount. But as I've said earlier, I'm a 3rd year PhD student. Even though I was aiming to recruit 50 patients, I had recruited 43, 31 had received their surgery, and 22 had completed all time points. So, as Bhuvana said, everyone was hit, and even though we were hit as well, we were in a very fortunate position that we could look at the data and provide some statistical worthy answers for our questions. So to conclude, it affected patient recruitment. We had to withdraw patients from the research. We had to stop follow-ups. We had a reduction in the sample size. And the other thing to mention is the natural interruption that COVID-19 caused. I felt I was getting quite confident in handling the day-to-day parts of the research job and recruiting patients. And I felt in a good zone that the research was had a nice flow. And the important thing is that COVID-19 did really hit a lot of people's flow, and everyone was then going back to their clinical roles. But let's not forget the detrimental impact of COVID-19, not only on research, but on patients' lives, staff, colleagues, friends and family. It's been a very difficult time for us all, and hopefully we will continue to stay safe and provide good quality research. Thank you very much for your time. I think the last slide is just a thank you slide, and if anyone has any questions, please feel free.
Thank you very much, Ashley. I think actually both you and Bhuvaneswari have given some really good insight into the challenges. But I think the key thing is that you had to both alter your study designs in order to adapt appropriately. Bhuvaneswari was slightly earlier in her research, so it had possibly a slightly bigger impact, whereas you were quite fortunate, Ashley, that to some extent that you were towards the end, although that means, the flip side is you don't have that extra time to recover. So I'm hoping that this has kind of stimulated some thoughts for those that have joined us this evening. And please do put any questions you have in the chat section if you don't feel that at the end you want to ask them verbally. And we'll get to them all at the end. So I'm delighted to now introduce our final speaker, I think, for the evening. So Mr. Marcus Taylor, welcome, and thank you very much for joining us. You're going to speak about the importance of COVID and non-COVID research during the pandemic, I believe, and you work in Manchester. You're one of the trainees in Manchester. Apologies for my things. You're currently doing your MD.
That's right. Thank you. First of all, slightly concerned that I'm the only one that Bhuvan has trusted to share my own slides this evening. So let's see how we get on with that. But as you've said, my name's Marcus Taylor. I'm one of the cardiothoracic surgery trainees up in Manchester, and I'm currently out of programme for a period of 3 years doing some clinical research, and I'll talk a little bit more about my research later on. But essentially, yes, as you've said, the brief that I've been given is to talk about the importance of COVID and non-COVID research during the pandemic. And I think what I'm going to talk about will probably bring together quite a few of the themes that everybody else that's spoken tonight has brought out during their own presentations. So essentially, as headlined, we're going to talk about COVID research and non-COVID research, and then I'll talk about my research experience alongside some other cardiothoracic surgery researchers working alongside me in Manchester. So in terms of COVID research, so I think we recognise that the situation of the pandemic is entirely new for almost everyone involved in research. There are perhaps some people who've been involved in some of the other viruses that have spread rapidly, but at a regional level over the last few years. So things like SARS, Middle Eastern respiratory virus, and those sort of things. You may have some senior researchers who've had some involvement in spearheading research into those sort of situations. But for the majority of people, being involved in something of this magnitude is extremely new. And essentially what that means is that we're limited in terms of the expert knowledge we have access to in terms of developing research and undertaking research in this type of environment. And I think the way we look at the graphs now, where there was such an exponential rise in cases early on, followed by a precipitous decline and then much more of a plateau now, means that we recognise that early on there really was such a time-pressured situation, and that was to contribute to research wherever possible in order to try and alleviate the problems as early on as possible. And I think where we are now in terms of COVID research is that research in the early stages was extremely difficult because the vast majority of people were tied up in clinical work, and as has been said, the slog associated with clinical work in these extreme conditions, particularly with the PPE and the levels of uncertainty around pretty much everything, meant that taking an active role in research in that early stage of the pandemic was something that was very difficult to do. And so I think now that, as we've said, as we're starting to come out the other side of it, now really is a key time to make sure we try and involve ourselves in COVID research as much as possible. And I think particularly from a surgical point of view across the country, we see that elective activity has not yet returned to normal levels. And I think within cancer surgery, so within lung cancer surgery for thoracics and also for urgent cardiac surgery, we are seeing a significant rise in levels of activity. But certainly for other surgical specialties, general surgery, orthopedic surgery, for these sort of true elective procedures like hernias, like hips, all that sort of elective work, those programs really haven't returned to their normal levels. And so what this means is that across the board, you tend to have an increased availability of clinicians now to be involved in research wherever possible, as their workload remains slightly reduced to what it was in the pre-pandemic environment. We also have an opportunity to develop skills and knowledge that are not usually accessible, and that very much comes from our patients presenting in new and novel ways, both in terms of coronavirus and in terms of non-coronavirus presentations. I think we've all seen discussions about how a greater number of patients are presenting with late-stage symptoms for diseases where we're more used to seeing them present with more classical symptoms earlier on in the stages of disease. So I think really, as much as we see this as a situation of adversity, there is also opportunity. And I think, again, the importance of setting up protocols early to facilitate long-term follow-up. And again, this harks back to what we've said about the numbers. And I think early on, when the numbers were so high, although it was the most difficult time to be involved in research, to my eyes, that was really the time where we had to try and take advantage of capturing as many of these patients as possible. And again, as we move into long-term follow-up, we're starting to see that the long-term outcomes for people who get better after COVID-19 are perhaps where a large amount of the research is going to be moving forward. And so any opportunity that we have to capture as many people as possible while the disease levels were highest is perhaps going to contribute a huge amount to long-term research and follow-up for COVID patients going forward. And I think, speaking to colleagues, being involved with things across the last few months, and then reading articles in sort of contemporary magazines, so the BMJ as well as the mainstream media, in addition to seeing what's being published by colleagues in more specialist and specialty related journals, I think the main thing that underpins the majority of the work that we're doing, both clinically and in relation to research, is collaboration. And I think within a hospital, you see that at an interdepartmental level. You see our emergency department colleagues liaising with critical care colleagues in ways that perhaps we didn't before. From a regional network point of view, so up in Manchester, I work at Wythenshawe Hospital, and we are one of the small number of centres across the UK that provides ECMO services. So the VV ECMO service increased exponentially during the COVID pandemic. I remember one of the critical care consultants saying that prior to the pandemic, the highest number of people that had been on ECMO simultaneously across the country was in the low 30s. And at the height of the pandemic, it was approaching 100. So clearly that has huge effects on how we deliver a model like that at a regional level. And so what we find is that the hub and spoke network, where all of the rest of the hospitals across the region feed into that one central hospital, that network became important, and communication between colleagues became particularly important. And essentially we had additional numbers of clinicians going out to other hospitals to assess patients to determine whether they need to be retrieved or not. And also what you found is that because we then had these much higher number of sick patients that we nursed for much longer periods of time in comparison to what had happened previously, we were then in a position to offer additional expertise to these centres that we hadn't been able to do before, because this regional network had become much more robust. I think in terms of national learning, I think my experience is that what's driven national learning is London being ahead of the curve of the rest of the UK. And so actually, I think we had London very much driving the national learning in terms of communicating to colleagues around the country what they'd experienced, what was coming, what had worked well, and what they would have liked to have known 2 weeks ago in terms of undertaking the necessary preparations. And I think in this contemporary era, we also see this with technology. Again, I'm aware of very large WhatsApp groups comprised of clinical directors of intensive care units across the country who were able to collaborate in what had worked well in some centres and communicate that to their colleagues locally. And I think the final point in collaboration that we've seen is with international research. And that's something I'll touch on a little bit later in terms of what projects we've been undertaking. But I do think that this has been seen by researchers across the world as an opportunity to involve people in collaborative international research. When we look at non-COVID research, I think as Bhuvana and Ashley have noted, it's important to recognise that there are, of course, significant barriers to undertaking non-COVID research, particularly at the height of the pandemic. So we've heard about routine research being disrupted by the pandemic. We've heard about researchers being recalled to clinical practice, problems with funding being diverted or stopped altogether, and new non-COVID calls for research and the funding that they bring with them temporarily halted, as the focus at the time was on COVID research. But again, we've heard that there are risks from simply stopping all non-COVID research. You've had patients who've already been randomised, some may have been given treatments, some may have been given placebo for diseases where it was already recognised that we know they do gain benefit from certain treatment regimens. And so to involve somebody in a randomised protocol and then cut them loose after they've been involved for a few weeks with no understanding as to when they may be able to rejoin that regimen is a very difficult thing to do in terms of patient safety and how you manage people's conditions. But again, that ties in with the increased difficulty in conducting face-to-face research in a pandemic, both because patients are being advised to stay away from the hospital if they don't need to be, and within the hospital itself, PPE is a problem, and the risk to healthcare professionals for what is recognised as non-essential services was clearly highlighted as a potential issue during the height of the pandemic. And yet, despite there being barriers, there are, of course, some non-COVID research opportunities that have been provided. And I think one of these is that we recognise that large amounts of data needed to be collected because high-level quality COVID research would be undertaken. And so what you find is that there will be these large swathes of data that have been collected that will have the potential to be used retrospectively down the line for non-COVID purposes, given that they have the correct ethical approvals to be used in that way. When I say fast tracking, I think this is a double-edged sword, because I'm always reluctant to say that something like this means that governance is reduced as a positive, because I think we all know that the governance that surrounds research is very important to maintain sort of ethical and moral standards, and that patient safety is being upheld. However, I think we also recognise that a lot of these processes are particularly laborious. And so I think what we found with COVID is that where possible, some of the minutiae of these things have been dropped to allow some research to have been undertaken as rapidly as possible. And I think that correlates with significant changes to working practices. And I'm thinking particularly of the introduction of telephone clinics and non-face-to-face appointments. I think for those centres that didn't offer those services routinely prior to the pandemic, introducing something like that would take an extremely long time to do. It would have to go through large amounts of discussion with several groups, would have to go to board level discussions, would have to be introduced in a small way. Those results would have to be analysed. And I think really you'd be looking at a period of in excess of a year to really be in a position to roll out something like that trust-wide. So I think the opportunity to analyse changes like that have been implemented as quickly as possible is probably going to be one of the bonuses that comes out of how we've been working over the last few months. And again, to hark back what I've said before, elective activities in a lot of specialties, particularly the surgical specialties, remain lower than pre-COVID levels. Medical students who are always keen to sort of be involved in as many projects as possible have had significantly less contact time and much more free time. And so I've certainly noticed over the last month or so that there's a rise in the availability of colleagues who are keen to assist in research wherever possible, while their clinical facing commitments are perhaps not what they were at the start of the year. And I think this ties in with what's also been said about where we are in terms of restarting research. And I think it's recognised that regular publications maintain constant discussions of chronic health problems. And I've read some evidence to show that for chronic health problems like chronic kidney disease, hypertension, diabetes, it's not the groundbreaking, practice-changing papers that really alter practice significantly. It's the small incremental changes over time that come out by lots and lots of papers being published on these subjects over time to maintain regular discussion of these things that allows practice to change slowly. And so I read an article that said in articles like in journals like the BMJ, New England Journal, the journal, the JAMA, articles on comorbidities and chronic health diseases like hypertension and diabetes are down 25% year on year in comparison to where they were 2019. We also know that presentation to hospital with non-COVID pathology has significantly dropped, and that there's a strong likelihood that those numbers will go up, and that sometime in the future research in these non-COVID diseases will continue to be of importance. And so the National Institute for Health Research have published a framework in terms of how they feel that research should be restarted. And so the framework for restart is a significant guidance document that's been produced that essentially says that urgent public health studies should be prioritised in terms of what's restarted first. Active recruitment of participants should be restarted, but clearly there's a significant need for the correct infrastructure and the correct oversight for this to happen. And so the framework for restart guidance documents very much talks about what needs to be done at a local level, a regional level, and a national level to determine what is appropriate to be restarted, whilst recognising that it is important to restart that particularly urgent research. And so they've essentially classified studies into three levels. So essential studies providing research for the pandemic is level 1. Level 2 evidence studies are those where the research protocol indicates an urgent treatment or intervention without which patients could come to harm. And level 3 studies are all of those other studies, not in level 1 or 2, including new studies for COVID, which aren't in level 1. So essentially what they've developed here is a roadmap for clinicians who are wishing to restart their research over the coming weeks and months. So I just briefly wanted to round off with a discussion as to what we're doing in Manchester. So I'm an ST4 NTM, formerly out of programme for research, and I'm undertaking clinical research looking at risk prediction and risk modelling in thoracic surgery. So this is all based on retrospective data that's been collected. So there's no active patient participation and no face-to-face patient contact. We have a core surgical trainee who's also out of programme, who's doing a slightly similar thing in cardiac surgery. She's looking at real-time risk prediction in cardiac surgery in the intensive care unit. And again, none of that is involving face-to-face clinical contact with patients. And we also have an ST7 cardiothoracic NTN who's been appointed as an ACL, who is overseeing the research undertaken in Manchester. And so myself and the core trainee have a combination of clinical and research commitments. But unlike London, we were not required to return to clinical practice full time. There was a thought that we might be needed to provide additional support in the critical care environment, but the space had been flexed in such a way and the workforce had been amended in such a way that this was not felt to be necessary in the end. And so essentially, based on the theme of COVID research and non-COVID research, in terms of the COVID research, so we've started to realise that as research fellows, we're well placed to add COVID studies to our research portfolio during the pandemic. I think when you're a research fellow, a lot of the consultants that you work with in the unit assume that you've got lots and lots of free time on your hands and you'd be delighted to take on any additional research projects that they've got. And certainly for COVID, that's turned out to be great because it's meant that if there's been any questions about are you in a position to take on some COVID research, the answer has been yes. I think in surgical specialties, we're very lucky because data capturing is often reasonably robust, I think, and that sort of feeds into the data that we are required to provide at a national level on surgeon and hospital-specific outcomes. So I think accessing large amounts of data that's been reliably captured has been perhaps more straightforward than it would be in an acute medical unit, for example. Undertaking analysis of critical care COVID patients has been more straightforward than it could have been, given that our core trainee who's doing research has been involved in critical care studies, and certainly some of the research methodology and some of the studies that she's been doing to look at real-time development of risk models has been of interest to the acute intensive care clinicians who've been interested in applying this type of research to their COVID patients. As we said, we've talked about telephone consultations and we've started to develop some qualitative studies to assess the impact of telephone consultations on follow-up. And I certainly think that this is something that will be here to stay. That would be very, very interesting to see the results of that data, because I think we're starting to realise that bringing a patient an hour across the city to sit in a waiting room for 40 minutes to have someone look at their wounds, tell them everything's okay and we don't need to see them again, and be discharged after 5 minutes is perhaps not the best use of their time or of our time. So I think that telephone consultations are going to turn out to be something that we use a lot more frequently. And we recognised early on that qualitative studies to assess this are very important. We were also asked to join an international collaboration. So I talked about international research beforehand. So COVID Surge is an international collaboration that's looking at the impact of COVID on patients undergoing surgery. So there's a couple of arms to that study. One is simply assessing patients who were scheduled to undergo surgery during the COVID pandemic. And the other is looking at patients who contracted COVID pre or post their surgery. And so the data that we've collected and contributed to COVID Surge, again, is a large body of robust data, which will allow us to undertake further analyses in-house that weren't required for the COVID Surge contributions. And essentially what we've seen is that the work being done by COVID Surge is already starting to be published. You can see that this paper from the Lancet says that this is an international multi-centre cohort study from 235 centres across 24 countries, looking at outcomes in patients with COVID-19. And so there's a huge potential for this global body of work to produce serious outcomes for both COVID-specific patients and, as a broader scale, as I said, for patients simply undergoing surgery during the COVID era. In terms of non-COVID research, as I've said, our research is not lab-based or patient-facing. It's not funding dependent. We're all employed as fellows, which is why we split our time between clinical and research commitments. No active patient participation. And so I'm rather embarrassed to say, after Bhuvana and Ashley's presentations, that there's really been minimal impact on our research from the pandemic. And it's meant, again, as we've said before, that there's been reduced turnaround time for manuscripts because clinicians are much more likely to be able to be involved given their reduced clinical commitments. So to conclude, we can say that the COVID-19 pandemic has significantly affected non-COVID research across the world, but all clinicians and researchers have an obligation to become involved in the ever-expanding range of COVID-related research projects. Despite the significant barriers that have been put up as a result of the pandemic, the current circumstances do present some new opportunities for research development. And I think we're recognising now that as the peak of the pandemic passes, timely recommencement of non-COVID research activity will continue to be of paramount importance. Thank you.
Thank you very much, Marcus. That was really interesting, and I think you covered a lot of points. And I think probably Bhuvaneswari and Ashley are now very jealous, and we're going to have trouble calming them down after that. But I think you're right. It's been a very different picture across the country, and I think that in itself will potentially have an impact on things. And I think that in the longer term, we've obviously seen that some of the charities in particular have been really hit financially, and whether that then kind of impacts more on research funding as well going forward. So I think we'll feel the impact of COVID, and both in COVID research and for non-COVID research for quite a while, whether it's directly in terms of recruitment and getting studies back on track, but actually setting up new, and as you said about the diabetes and hypertension kind of papers in particular, they rely on that kind of ongoing research work to influence practice and influence results. So I think we're going to see quite a big impact over time. So I think it's my pleasure now that I can open up, if I'm waiting for a nod from Bhuvaneswari, that I can now open up for questions from everybody. So I don't know what the etiquette is, but do feel free to ask a question either on chat, to unmute yourself and please ask a question.
So there is a question for you.
Oh yes, it's from Tracy. Good evening. Good evening, Tracy. Thank you for your question. So the question is that we mentioned about the Lancet report and then mentioned about the importance of postdoctoral complications, and can I expand? So yes, I'll try and provide a slightly brief response to that. So the Lancet report was a report looking at the impact of surgery across the globe, and it looked particularly at the countries that did and didn't and weren't able to perform research. So it was also looking at low to middle income countries, and that's where the figure of greater than 4.5 million patients were not able to have access to cardiac surgery. I think the bit mainly about postoperative complications, certainly if more and more people are obviously surviving surgery, and it's becoming much more common for you to leave hospital after surgery, but because of increasing age, a lot more comorbidities being experienced by individuals, etc., and the fact that we can actually perform much more complicated surgery, so people are able to survive surgeries that maybe they wouldn't have done so in the past, it actually makes recovery more complicated. And so looking at things in particular like how long it takes to return back to normal function, with wound complications, particularly those in hospital. But actually, a lot of patients experience complications outside of hospital once they've gone home, and they might be conditions that we would consider particularly minor, i.e. they don't need hospital treatment, but they still have an impact on life. And we conducted a patient and public engagement event a couple of years ago, and about between a third and a half of those patients that were about a year after having their surgery would have said that they wouldn't want to have had surgery if they knew what had happened to them. They knew that before. And so I think there's a lot more that we can find out and give hard evidence or give evidence for that can actually inform the informed consent process, and engage patients a little bit more in their recovery and what to expect. This isn't the bog standard 6 weeks that we kind of generally communicate. Certainly our patient group were very much, that's a complete lie, please tell everyone it's about 18 months. So please don't say Professor Sanders says it's 18 months, not 6 weeks, when you see all your patients, because that will get me into big trouble. But I think it's about being realistic about the fact that everyone miraculously doesn't feel much better than previously. But certainly Ashley's research has found some interesting findings about how quickly and patients' perceptions of their recovery. I hope that answers your question enough.
No, that's lovely. Thank you very much, Julie.
Thank you for your question. We have a question from Krishnamoorthy here. Do you want me to read shall I read the question out? The question takes off topic but still fits in, of course. With the advancement of medical specialities as well as the introduction of endovascular procedures, we see that not as much of the research work in CTS as there should be. So how all of you see the future of our field? Who wants to take that question? Marcus, do you want to take that question, or Bhavana?
Fine. So I'm happy to kick off. So I think you've made a good point, and I think the point that you've made ties in with the point that Julie's made, which is the one side of research is about technology and development and developing endovascular procedures, and certainly in thoracic surgery we have video-assisted surgery and now robotic surgery, and in cardiac surgery you have the development of, again, port access mitral surgery and minimal access cardiac surgery and robotic surgery, in order to keep pace with the results that are coming out from TAVI trials and MitraClip trials. And so I think it's clear that there will continue to be development in those areas, particularly given that a large amount of what happens in those fields is driven by the funding that comes from American centres. But I think the other thing that we really need to focus on is outcomes. And I think this ties in a lot with what Julie said, which is we've never really done a huge amount of work about how people feel after surgery. And I think this is really important now in terms of the fact that you have emerging treatments that are comparable to the treatments that we offer. So I think this is true of TAVI in high-risk aortic valve surgery patients. And I also think this is now true in thoracic surgery, where we recognise that SABR, so stereotactic body radiotherapy, has broadly similar outcomes for the smallest tumours, for those T1 tumours, for patients with early stage lung cancer. And so all of a sudden just saying you'll have an operation, you'll feel bad afterwards, you'll have some complications, but then after that you'll feel better when you feel better, is no longer acceptable practice when someone has a treatment that is significantly less invasive that may not necessarily give them a much worse long-term outcome. And so this is something particularly in thoracic surgery where for years we've quoted perioperative mortality, meaning 30-day and in-hospital mortality, as your endpoints. And you say to someone, your risk of dying after a lung resection at 30 days is 2%. So that's all very good. So you should have that in comparison to SABR because it may be better for you. But actually, as we've done some more research in this and found out that actually 90-day mortality after lung resection is double 30-day mortality, that very much alters the context in which you say to somebody, your risk of dying after this operation at 3 months is 1 in 20, whereas something that isn't invasive, like a bit of radiotherapy, given that your tumour is only a centimetre, may give you the same long-term survival without any of the potential mortality and morbidity associated with an operation. So I think as much as we continue to develop the technological aspects of surgery and continue to develop what we offer people, I think alongside that, we need to make sure that we're not forgetting about doing research into exactly what it is that we offer people and how we present that.
Thank you. I hope that answers your question, Amor. So Jenny has submitted a question. There's a need for nurses and allied healthcare professionals to be more involved in CTS research. What would be your advice to those who need to research and want to get involved but don't know where to start? And equally, how can we encourage nurses and APs to get involved? So I think that's a really good question. I think that's certainly something that we're trying to do, Jenny, through the SCTS, because there aren't many of us. So actually, to be able to provide support and supervision, that you need that critical mass. And I see that Naz, I think, is on here as well on the call. And so we're trying through the NAHP, for example, to be able to support and ask questions. So we do ask that if you're interested in research, to join that group, because that's how we disseminate information. But that also gives you a way in to any of us that can ask questions, or answer questions or provide support. So really happy to talk to anybody about opportunities, either personally or how you can get engaged. But certainly at centre level, if you want to get more engaged in research, you will have hopefully a trainee or a nurse, another nurse or AAP aligned to the Cardiothoracic Interdisciplinary Research Network. And if you don't have anybody at your site, then please make yourself known to us and we can put you in touch. So I think the research meeting in November would be a really good place to come. We will have a breakout session for nurses and allied professions, kind of over lunch. I know it's a webinar, so you have to bring your own lunch, I'm afraid. But we can all munch away and kind of get to know each other a little bit. And we're setting up a subcommittee so that we can actually maybe do more webinars, put more things and develop things on the website to make ourselves slightly more accessible and known. So I hope that helps, but I'm very happy to take questions. Vana has my email address, but I think it's also on the SCTS website, and I'm at Bart, so please do get in contact if you have any particular questions relating to getting more involved, particularly if you're interested in doing a PhD. Can we take one last question, Bhavana?
Yeah, final
that's
question,
right.
please.
Yeah, one last question. What has been going on regarding blood transfusion and heart transplants despite COVID-19? Who can answer that one? It's not something I know much about.
Marcus?
So I can say something very quickly about transplant, although I don't know about blood transfusion. So transplantation pretty much completely stopped. And there's two main reasons for that. Number one is the significantly higher risk of people catching COVID whilst they were in hospital on immunosuppression immediately after transplants. And number two is that the transplants and mechanical circulatory support network was very much geared up towards providing veno-venous ECMO for COVID patients rather than providing the normal service. So I think certainly in Wythenshawe, during the main peak of the pandemic, we did 1 or 2 heart transplants, and that was for people who were in hospital on short-term mechanical circulatory support on the super urgent list, but nothing else. We did no lung transplants up until very recently because of the increased risk of them getting COVID in their immunocompromised state.
I will answer the blood transfusion because we had ECMO in 2 weeks before, and one of the anesthetists was saying that it is increased actually the blood transfusion, and all the patients have been screened appropriately to check whether they have COVID or not. And there are lots of people who are working overtime. And my neighbor is a transfusion nurse, and she was saying that she is doing double the shift to make sure that everybody is tested and everything, and the transfusion is increased actually.
So I think this comes to me to close the this very interesting webinar. So I'd like to thank everybody that's taken part and presented this evening. So thank you, Bhavana, Marcus, Ashley, and also Carol, who left a little earlier. Jeni, thank you very much for co-hosting with me this evening. It's been a pleasure. And thank you all to logging in, and also for your questions. It's been a real pleasure, and please do get in touch with any of us if you've got any additional questions.
Thank you so much. Thank you so much for everyone. Thank you, Jeni. Thank you, Julie, for coming and doing this.
Thank you very much.
Thank you.
Thank you.
Thank you, everyone. Have a good evening.